Hi, my name is Matt Kappas. I'm a transplant hepatologist at Duke University Hospital, and I have the distinct privilege of being with Dr. Zachary Gitto from University of California, San Diego. I'm going to have Zach introduce himself, but he is the lead author on a upcoming article entitled Nephrology for the Transplant Hepatologist in Clinical Liver Disease. And so, Dr. Gitto, could you introduce yourself?
Hi, yes. Hello, everyone. I am currently a transplant hepatology fellow at the University of California in San Diego. This article on transplant nephrology for the hepatologist or nephrology for the transplant hepatologist is really geared towards giving a review for gastroenterologists and hepatologists who run into patients with cirrhosis who have renal issues either pre-transplant or post-transplant, and try to provide a synopsis to review to make that a little bit easier.
Excellent. So it really sounds almost like a review of general internal medicine for the gastroenterologist. Can you tell me a little bit about what inspired you and your mentor to approach this topic?
Absolutely. Very frequently, our gastroenterologists in our community hospitals and even in our academic hospitals do encounter transplant patients or end-stage liver disease patients being evaluated for transplant. And one of the things that tends to fall on the GI or hepatologist is what to do when you're concerned about the patient's kidneys or related issues like hypertension or hyperkalemia in these patients, either pre or post-transplant. And the management that maybe typically should fall to a nephrologist or even the primary care doctor, at the very least, the gastroenterologist may be involved in management or at least needs to be aware of what the options are and how to approach these issues.
That's great, Zach. I mean, these patients are complex medically. They're coming into transplant with predetermined kidney disease in many cases. And then after transplant, they're certainly being exposed to medications that raise the chances for the development of either progressing or eventual chronic kidney disease. So you can see exactly where you're going with this. Can you give us a short synopsis of the article?
Yes, the article here is broken down into a couple of stages. The beginning of the article touches upon the pre-transplant scenario, and in general, how to identify your cirrhotic patients who have kidney dysfunction. Typically, serum creatinine is our gold standard measurement to estimate someone's creatinine clearance and kidney dysfunction. There are some caveats to that in patients with cirrhosis, in that these patients tend to have significant sarcopenia, significant muscle wasting. And so we talk a little bit about how to identify renal disease and then how to approach it in a patient that we are thinking about the possibility of a liver transplant. And then we go on a little bit later in the article, taking that same patient further down the line in the post-transplant setting or in the peri-transplant setting. When do we think about offering a kidney transplant in addition to the liver? And after a liver transplant, how do we approach in the liver clinic their electrolytes and their kidney function after the transplant?
Excellent. So really a comprehensive review, and probably fairly quick read as well, to give sort of the high points between before and then all the way through after transplant. If you
To be a complete review, intended to be sort of a nice guide for the hepatologist or gastroenterologist for the broad strokes of these issues, and I think things that they will need to know when seeing these patients.
Perfect. Are there any, if you had to list maybe 2 or 3 pearls from that a reader will take from the article, would you be able to leave any?
Absolutely. I think the pre-transplant scenario is always challenging, and it's nice when you have a nephrologist or a transplant nephrologist specifically to be there to guide you, but I think we need to be aware of these issues. The diagnosis and management of hepatorenal syndrome in cirrhotic patients and pre-transplant kidney dysfunction is always challenging, given the physiologic changes that come with cirrhosis. So we will, discuss, I think our pearl for pre-transplant care is how do we manage hepatorenal syndrome with the recent FDA approval of terlipressin that does change the gamut a bit. Previously, there are no FDA-approved indications for hepatorenal syndrome. We typically use midodrine and octreotide, which have had some efficacy but limited effect. Norepinephrine has shown some promise, though it's not FDA-approved for this indication. So now we have an FDA-approved indication in terlipressin, and so there are certainly caveats in when and how to use that in our patients. The main idea being this can increase the chances of reversal of HRS in the pre-transplant liver patient. It does have risks, primarily volume overload and respiratory failure, and lower rare risk of intestinal ischemia. And both of those issues can preclude transplant if this drug is used incorrectly and has adverse effects. And so there is a select population of patients that this may benefit. So terlipressin use and when and how to use it is probably the most important new development in the pre-transplant cirrhotic world. And then in the peri-transplant setting, and when do we get transplant nephrology involved, and who should get a liver and kidney transplant? The pearl there is that the OPTN developed guidelines for this in 2017. Previously, that was very variable across institutions. But now we know that if your patient has a sustained kidney injury for more than 6 weeks, you must be getting creatinines on them weekly and have a transplant nephrologist involved, because the guidelines allow for liver kidney simultaneous listing if they have a sustained GFR less than 25 for 6 weeks. And similarly, in your CKD patients, if they have more than 90 days of kidney dysfunction, they outline what criteria those CKD patients would need to meet to receive a liver and a kidney transplant. And so those are relatively new in the past few years. And I think it's requires the gastroenterologist or hepatologist to be aware that those guidelines exist and they need to be consulted if your patient has kidney dysfunction along with their liver disease and you're thinking about transplant. And then the final pearl is the post-transplant setting. Some of these issues are early transplant, where the patient will be followed by the post-transplant team, but many of them can persist after they go back to their community doctors or their local doctors. And those are primarily longer-term kidney dysfunction or hyperkalemia and hypertension, which have all been demonstrated to be problematic in post-transplant patients and are very important primary care issues specifically for these patients that we need to know about.
Fantastic. Sounds like a great article, and I appreciate the fact that this is not a comprehensive review, but really an opportunity to expose readers to the issues, as well as providing references to follow up with additional knowledge. So, Dr. Gitto, I appreciate your time today, and I encourage all the listeners here to cue in and check out this upcoming article in CLD entitled Nephrology for the Transplant Hepatologist and Gastroenterologist. Thanks again.